And we have a lot of people that unfortunately are still working full-time jobs, and they cannot be here today. So that replay will go out. So for those of you who are talking to other people in the groups, let them know replay will go out for sure. So we are talking to Dr. Shawn, and I get this wrong. Is it Tassone?
Yep, you got it.
Dr. Shawn Tassone, MD, PhD, a physician, double board certified in obstetrics and gynecology and integrative medicine. Combined with his PhD in mind-body medicine, he believes that the best model of care is self-care, and the medical paradigm will serve patients better with an active patient, yes, and a passive physician. You never hear that. It's awesome. He's an author, speaker, and women's health advocate traveling around the world speaking on issues of hormone imbalance, integrative women's health, and alternative options for health. He is an assistant professor of women's health at the University of Texas Dell Medical School and has a private practice in Austin, Texas. I love Austin. Love it when we visited there. So
right.
Welcome. I'm so glad that you're here. I really want to start out with the question that has come up so much that maybe you can give us a real nice definition of what in the world is progesterone to estrogen ratio, and what is estrogen dominance? I want to leap right into it because it comes up like you would not believe.
So one thing is, it's funny, I put a post on LinkedIn about a year ago talking about estrogen dominance, and an endocrinologist who must have been on my list or following list texted or responded to my post and said that estrogen dominance doesn't exist, kind of like adrenal fatigue. And I said to him, I said, well, technically you're right. In the medical jargon, there's no diagnosis code for estrogen dominance. But I said to him, what would you call a woman whose estrogen is 400 and her progesterone is 0.2? Mm-hmm. You have to call it something. And he never responded. So I think you have to look at estrogen dominance as kind of it's a syndrome, kind of like PCOS or one of those things. But if you look at the ratios, I like to see a ratio of estrogen to progesterone of about, and I'm talking mostly estradiol to progesterone of about 10-1. And most women are more like 100 or 1,000 to 1 in most cases. I would say out of the 12 hormone deficiencies that I treat regularly, estrogen dominance is probably 75% of them. I mean, it's really common.
Yeah, which is why I think it's coming up so much in our groups with our clients. They might even say, well, my doctor says that I have no progesterone, but I have no estrogen either. So how can I be estrogen dominant? Like, nobody understands this at the medical level, or even honestly, just understanding it in our bodies. Even some women are like, oh, I don't understand what that means to have too much estrogen. So go on.
Well, it's just that in the first, and it also depends on when you have I believe personally, and this is my personal beliefs, and probably just from my own background and training, there's two aspects to hormones. One is the physical aspect, right? So you can draw the labs, you can look at it, you can see it. But there's also, and without sounding too woo-woo, I think that there's an energetic side to this too. There's an emotional side, there's a psychological side. So estrogen dominance doesn't necessarily have to mean that it's just your labs. It could mean that you have a lot of the symptoms, that you're feeling a certain way. And I kind of like to look at it in both of those terms. So, because I have a quiz that is coming out in a couple of weeks where I'm going to ask like 36 questions, and it's going to give you a hormonal archetype. So estrogen dominance, for instance, would be the queen. And the queen, there's good queens, there's bad queens. And I talk through spiritual practices and nutrition, exercise, supplementation, things like that. So I don't like people to just get hung up on that. But you also have to look at it like different times of your cycle. It might be normal to be a queen in the proliferative phase in that first half versus in the second half. You shouldn't be estrogen dominant in the secretory phase of your cycle. You should be progesterone dominant. So it matters when we're drawing these labs, if we're doing labs. But we're talking more women that have these problems more often than they don't have them, right? So, right. Yeah.
Not just at specific times during the cycle.
Right.
If you're a regularly cycling woman. So, that kind of leads me into me no longer being one of those. I'm post-menopause. You've had a unique look at my Dutch test. I'm a hormonal disaster, and thanks for the help that you've given me and the guidance. But what about those of us who have gone through that change? And we're still told that we are estrogen dominant, or that we're not processing our estrogen normally. Like, we don't cycle the same way, do we? Like, we don't have lower at specific times of the month and higher at other times. Is it that way only during stress? Like, what does it look like for someone like me?
Well, it depends, first of all, on what you're taking and how you're taking it. So, are you using a cream? Are you using a sublingual troche? Are you using a capsule, which is, those are going to get destroyed by your liver, half of the dose. Are you using estradiol, estrone? What are you getting? And so there's a lot of other variables in there. But and then there's some doctors that will prescribe that they'll cycle patients versus others like me that just, especially somebody like you, I just usually keep it status quo. And then you have women that are on pellets, and I personally hate pellets, but we have women that are on pellets. And so, you can be estrogen dominant, be menopausal. You might just be on the wrong dose of medication, or you might be absorbing it differently, or you might not be methylating it appropriately, like you mentioned. There's a whole lot of different things, of course.
Okay, so let's talk about the types of estrogen, because I don't think people realize, and even I, up to probably 4 years ago, wasn't aware of the definition of all the different types of estrogen. And so, can you give us an idea, what is estriol, estrione, estrogen? Like, can you run us down a little bit of the definitions of those and what they do?
Right. So they're all, the estradiol, first and foremost, is the most potent of the three. So you'll see a lot of patients that might be on Biest, or used to be Triest, but they switched it to Biest because estriol kind of got a shady deal from the FDA. And the reason that happened was because, unfortunately, there were a lot of prescribing compounding pharmacies that were promoting it as cancer protective and things that weren't necessarily false, but they weren't necessarily true. And so the FDA really came down on it. But Biest contains estradiol and estrone. Now, there's a lot of camps out there that think that estrone, which is the weakest of the three, also, or second weakest, the estriol is the weakest, but estrone might be the one that causes more cancers or is damaging to the DNA if it's not methylated. So in that Dutch test, if it goes down and doesn't get methylated, it can damage the DNA. So I tend to give, when I do replacement, I usually don't use Biest anymore. I usually just use estradiol because I'm going to get less of that breakdown. Or metabolism, especially in most of us, because a lot of us don't methylate very well, to be honest. So you got estriol, which is the weakest, estradiol, which is the strongest, and estrone, which is in between. Now, in the body, the most predominant one is estriol. So the weakest of the three is about 80% of urinary metabolites. Estradiol is about 20%, or 15%, 10%, and estrone is about 5 to 10%. So the most of the circulating hormone in the body is estriol.
Okay. So does it bypass, when you say that you prescribe estradiol, does it bypass that methylation process then, if you struggle to methylate properly and things like that? Is that why you do it?
Mostly, but estradiol can move into estrone as well. So it's, it's just something that you need to watch, which is why I really like the Dutch test, because it gives you those metabolites, which blood tests don't do.
Yeah.
And that's recent. I mean, that's in the last couple of years, we were giving, and the other thing is, this is what a lot of women you're going to see this, is that a lot of women, even ones that don't have breast cancer, are scared still of estrogen because of the Women's Health Initiative that came out about 10 years ago. But that was Premarin and Provera, and Prempro. The combination of the two had increased rates of breast cancer. But the arm that only had the Premarin, or the estrogen only, which is a horrible estrogen anyways, but that arm actually did not have any increased rates of cancer. And actually there was a 50% decrease in colon cancer rates, but you didn't hear about that. So you can't even really compare these two products because they're completely different. And so, and there's never going to be any great studies on estradiol, because there's no money, right? So big pharmacy doesn't really have a chokehold on it. So, it's just something that we have to be careful in the verbiage that we use. I still will consent patients for hormone replacement, because a lot of women find me through Suzanne Summers' books, and I don't necessarily follow everything that Suzanne Summers says. And obviously, like any medication, there's risks of, side effects.
Sure. Yeah. Okay. So let's talk about what comes from being estrogen dominant? What are the problems you can experience with estrogen dominance? I had them all, I think, before I had my hysterectomy. So growth, the fibroids, things like that. Let's tell me a little bit about what people can experience with and kind of know, well, that's coming from estrogen dominance.
So you mentioned fibroids, ovarian cysts, you have fibrocystic tissue in the breasts, irregular periods or heavy menstrual periods, endometriosis, adenomyosis, pelvic, which then cause pelvic pain, retention of water because estrogen will make you hold on to fluids, which can cause weight gain. Estrogen can actually decrease insulin sensitivity to a certain degree. So that's why, and we don't know exactly why, but women that PCOS that have higher estrogen levels also have higher insulin levels because they're insulin resistant. And so it can cause metabolic issues. Estrogen dominance can also cause breast cancer and uterine cancers. Now, I often tell women estrogen doesn't cause cancer because if it did, every woman would get cancer.
Right.
It can potentiate estrogen receptor positive cancers, obviously, but it doesn't necessarily cause cancer. And the other thing is, if to use the queen metaphor again, if you think of the Queen of Hearts in the Alice in Wonderland running around wanting to kill everybody, estrogen dominance can make you feel like that. You feel like you just want to rip everybody's heads off. And because it's just out of whack, because the progesterone is the calming hormone. And if you don't have that, then you're out of your mind most of the time.
Yeah.
You feel like it.
Yeah. And I think that's a great point. So many times, when I've worked with people in the past, they'll say, well, it's just PMS. I get super irritable. I bleed so bad. I have to stay in bed. I have terrible cramps. It's just PMS. And I'm like, that's not normal. Like that, in my mind, that's common, but it's not normal to feel that way, right? Like there's so many people have said that this is a normal way to feel when you have PMS. And the more I'm learning about this kind of thing, I'm like, all the years I didn't have to live that way, right? And I was probably more than likely estrogen dominant, low in progesterone.
Well, the reason that they're saying that it's normal is because they're probably being told by the medical community or a man somewhere. I'll take the blame as a man, being the only man here, that it's just PMS, that it's normal. In our society, we just kind of minimize. But I can tell you, if men missed a week out of the month because they had PMS, it would be fixed. It wouldn't be fixed, right? So I don't think it's normal. There's absolutely no reason why you should suffer. And in most of those cases, it's progesterone deficiency in the second half of the cycle. And you can see some pretty dramatic shifts in somebody with just giving them 10 days of progesterone in the second half of their cycle. It's like night and day. Yeah. And they've been suffering for years, you know?
Gosh, I'm glad you said that, about if it were a man, it would be fixed because my problem started back in the late 1990s. I had, endometriosis I had to have taken care of. They were like, oh my gosh, you're covered in it. I was never one to have long periods. They only lasted like 3 days, but the cramping was insane. Then fibroids showed up 10 years later. I never knew, no one ever said, you know what, you've got to look at your phytoestrogens and your xenoestrogens and how are you getting too much? And let's look at not one person. And I had a baby and everything. Like I was a grown woman when I finally ended up having a hysterectomy because fibroids were just massive and I was miserable. Why are doctors not talking about this with people? Why is this? It seems like just common sense to me.
Well, take for instance, my wife is an OBGYN and she's actually integrative as well, but she has a very traditional practice because somebody's got to pay the bills, right? So you're talking about the coaches. It's like I was going to say, marry somebody that makes a lot of money like I did. But what happens is she sees 50 patients a day, right? So you can't spend that amount of time to explain all this. And to be perfectly honest, I would say that most OBGYNs probably think they already know everything about hormones to begin with. Mm-hmm. And then the flip side of that, though, is you have these hormone clinics opening up on every street corner with a doctor or a nurse who basically went to a weekend course, and they're putting pellets in patients. They're reading the labs wrong, and it's becoming a disaster because there isn't a voice of reason, I don't think, right now. Maybe Sarah Gottfried and a couple of others, but Sarah doesn't practice, and probably in a few years, I'm not going to be practicing either. But hopefully, we can train coaches, and that's my goal eventually, is to really have in-depth training for health coaches like you see in hormone replacement, so that they have that understanding, so that they know, not necessarily what to prescribe, because you can't, but what they're on, what are they taking, and they'll know. The best thing for health coaches to know is, are you on something that makes absolutely no sense, right?
Mm-hmm, mm-hmm.
And because I can't tell you how many patients I see that are on the craziest formulations that is so difficult to follow. And I think it's like sometimes we make it more difficult because it makes us look smarter in a way.
Oh, yes.
Right. And it's like,
Yes.
it's not that difficult. I always tell patients, let's break it down. You're taking like 7 different things at 3 different times during the day, and it's just insane. Let's make it easy. And she's like, oh, I can do that. And yeah, you can. But
Yeah.
doctors, just as far as the traditional physicians, it's just, I think it's time consuming, and nobody likes to admit that they don't understand.
Yeah. And so, okay. So going back to what you said about health coaches, and, I would love, and you might already be doing and thinking about this, but even, providing the training for health coaches around that topic, because we have great trainings out there by, many people that talk to coaches about how do you help people recognize it? How do you help them reduce estrogens in their life? But we don't have anyone talking about this. How, what types of hormone replacement there are, why this is, even about the Premarin and stuff, like many people didn't even know about the horse urine and all of that from a long time ago. They just automatically formulated an opinion about estrogen, and it's off the map. And I see, I have to say, I've seen a lot of clients that are like, I'm not taking anything. I won't use hormones. I don't want cancer. I'm like, okay, that's not it. That's not how it works. I want to send you, some information. Once you read on it, take it to your doctor and have a conversation about this, because you have no hormones left in your body at all, and you're a miserable person, but the fear is, it's just already been set up in them to worry about it, So let me give you an example of someone that I worked with one time, and you tell me what could have happened here. So she was given a progesterone cream, and he told her to rub it on her chest, like all, on her breast tissue.
Right.
I think that she did that for 3 years, I think was how long it went on, without testing, without following anything that was happening, like not checking levels, nothing. She developed so many cysts in her breast, like when they tried to take a sample, the needle broke off in the cysts. They were so hard. She ended up having a double mastectomy. What could possibly have happened there? Like, where did things go wrong, besides the fact that they didn't test her? How could that have possibly caused something like that to happen?
Wow. You almost have to dig pretty deep to find out what's going on there. I'm not a big fan of rubbing the actual cream on your breasts. I have received a lot of patients that were told to do that. I don't know where that ever came from. But it's not, and I can't think of any reason why putting somebody just on progesterone for years without testing them, it doesn't make sense. It's actually, I don't like to be judgmental, but that's a little negligent in the sense that you can't, I do it at least once a year. You got to know where women are, or anybody. If I was on testosterone as a man, I'd want to know where my testosterone level was, because too much of a good thing can be bad, just like we've been talking about.
Right.
But yeah, that's just one of those things. I've never seen fibrocystic breast so hard that it breaks a needle. That might be an anomalous case.
It was horrible. It was awful. It happened to her 3 times when they went into 3 different sections of her breast. They broke needles, and she said, that's enough. I can't take it anymore.
Yeah.
Crazy. So, okay. So let's move into some conversation about your, and I'm reading notes here about where you talked about your explanation of estrogen, of hormone types of women, the queen, the nun, all of those. I want you to kind of run through what the definition of those are. And by the way, you guys, we will get to questions in a minute. But I want you to, Shawn's got a book coming out. I think it's going to be super helpful for everyone. But I want you to touch on that. Where'd you come up with those titles?
So one of the big things in the question that, you even mentioned this before, this is the first time you've ever had a man on your, your coaching academy. And so obviously a big question is, why a man? What are you going to tell me that Sarah Gottfried can't tell me, or somebody like that? I guess the way I look at it is, my superpower, if I have one, is listening. I'm really good at listening. And my PhD was actually on narrative life story. I really, really like stories. I like the life story. So over the last 15 years, I've probably seen 40,000, 50,000 women for hormone replacement. And these 12 hormone imbalances, these archetypes, these stories came out of those 50,000 interactions. So it's not me necessarily telling women what to do. It's stories that are just kind of being shared. And what happens is when I speak this language to patients, for instance, I had a lady come in the other day. She's a pharmaceutical rep. So obviously, a lot of pressure on those women to be very attractive and thin, and because they're in a man's world usually. She's working horrible hours. She's driving thousands of miles a week to cover her territory. She's working out crazy. She's got 3 kids that are under the age of 6, a husband that's not super supportive. So naturally I did, she comes in, she's worn out, she feels horrible. I did a Dutch test on her, and her cortisol was like in the tank. It was just like 0. Amongst some other things. But so I looked at her and I said, your cortisol is low. And there's like this, whatever, I don't know what that means. So what I then do is I'll go into the discussion of this archetype, this hormonal type, which I call the saboteur. And the reason that I call it the saboteur, I told her, is saboteurs do everything for everybody else. They don't take care of themselves because they're always taking care of other people. And then they're burning the candle with the blowtorch. So when I say this to her, she starts crying because she says to me, for the first time in years, you've said in like 3 sentences exactly how I feel. And I said, this isn't me. This is just listening to all these other women tell me the exact same story. And so we put her on, some adrenal cortex and some things like that. And she, and actually told her to stop working out because she needed that extra energy to come back, And so it's really, it just makes the conversation a lot easier. My friend, Larry Dossi, has this theory he calls the beef stroganoff principle. So he has this friend who owned a restaurant, and they used to serve beef stroganoff, and it never sold. Nobody wanted it. It was in this small mountain town in Colorado. And he's like, I think I'm going to take it off the menu. And Larry said, well, it's so good. Don't take it off the menu. Why don't you just call it beef with noodles? Maybe nobody knows what beef stroganoff is. So he changes it to beef with noodles, and 15 years later, it's still like one of the best-selling entrees at the place. And the point is, and this is really important for coaches, you need to talk the language. You can't speak a different language, especially to physicians, especially to patients that are learning from physicians, because if you do speak another language, people aren't going to listen to you. And so when I'm a doctor talking to a patient, if I say cortisol is low, they're going to be like, whatever. But if I can say the saboteur, this is why, that's where I just think it makes it, that's, I think, what separates what I'm trying to do from what other authors have already done.
Yes. Yeah. And that's, I like that, because for me, I need things in bite-sized pieces. And this goes back to kind of like when I reached out to you, I'm like, well, you look at my Dutch test and you gave bite-sized pieces. You didn't give me this big, long dissertation about all of these things that were happening. It was like, oh, okay. Yeah. And I've worked with a lot of practitioners in my time I chased symptoms for 10 years before I was diagnosed by myself with Hashimoto's and requested a test, and it was positive.
Mm-hmm.
So for me, I appreciate that fully, not only because it helps you to make sense of everything you're saying, because you're doctor, but the other part is this: you're not saying to someone, you're not giving them a death sentence. Your cortisol is low. You are going to burn out. You're not doing that. You're saying, hey, you deserve some self-care. And I think a lot of practitioners are not doing that today. Conventional doctors are telling our clients, you absolutely need this. You've got to do this. They're not talking to them like they're people with lives and children and jobs. You know what I mean?
Yeah. Exactly.
So it's very appreciated to hear that, to hear it come from you that way. And I think that we can learn a lot from you in saying that. So let's go back to you've got a couple other things here. Talk to me about the nun. What's the nun in your hormonal archetype?
So the first thing is, there's no good or bad per se. So I don't want women who test into the nun to think, oh my God, nuns are off, whatever. But
like I just did, was because I'm the saboteur, and I went like, oh my God, that's me.
Yeah, but so there's a good thing. Saboteurs do good for other people. I mean, they take care of other people. They just don't take care of themselves. The nuns are great. They're very loyal. They're educated. They're dedicated. They're very usually they're very intellectual people. The downside to the nun is testosterone deficiency, and that's kind of the big point, because the good nuns obviously don't have sex, right?
Yeah.
So
The good nuns.
so that's the point. But the nun being also the spiritual practice that I include for the nun, because nuns tend to be cloistered or they separate themselves. Nuns, I think, need to get out and be with other people. They need to be around others and not cloister themselves because they feel different. And most of the time I see a woman that has testosterone deficiency, she's coming in because her husband's telling her there's something wrong with her, right? Because, oh, you don't want to have sex with me. What's wrong? Don't you love me? I have seen women turn it around after they get on testosterone therapy, and then their husbands don't want to have sex because the woman wants to have sex too often. And a lot of that is just a mental shifting as well. You feel a little bit better. But I always joke around. One, if it's funny, I always ask patients, why did you come in? Did you come in because you have a problem or because he thinks you have a problem? And it's usually because he thinks you have a problem.
Right.
But I always tell the guys, if they come in, I will tell the guys, rule number one for decreased libido, she doesn't have sex with jerks. So that's rule number one. Mm-hmm. Rule number two is, if you, instead of going up to her in the kitchen and kissing her neck, maybe do the dishes. That's good. So it's not because she doesn't have an elevated testosterone. It's because she's tired. Or, how many of you guys, if I ask you what's the top 10 things you need to achieve today, you're going to put sex on that list? Probably 0, maybe 1. And guys are going to put it in the top 3, probably 5. So there's a mismatch there. And I think, by raising testosterone, we just make you feel better, more energy, a little bit more, self-worth, that makes you more interested in sex. So, it's a whole story too. But there's other things you can do, like essential oils and supplements. And so for women, there's a lady here that just made a comment about not wanting to use big pharmacy or medications. And obviously there's other things you can do.
Yeah. That's a great analogy, because I'm listening to a book called Come As You Are. Have you heard of that book? It's oh my gosh. What you're saying is really pushing home. I think you'd probably enjoy it, but pushing home the different types. I wish I could remember the author's name, but I'm doing it on Audible. What you just said about, how different women are from men, and how men it's almost like they don't even get it. And almost like, they don't understand. We don't have the same sex drive as they do. We are first going to take care of that top 10 list. And then if we have energy left over for sex at the end, then maybe we'll get there for not sleeping on our feet. Right.
Right.
And I have a therapist who always says the best foreplay is helping her clean the kitchen, helping her vacuum the floors, do something around the house that relieves the pressure from her. So to hear that coming from a man is really, it's really refreshing, because it's so
well.
true.
This man is married to a woman who had to educate me. I'm not pretending that I am perfect.
Totally.
But this is something that I learned. I learned that doing the laundry doesn't mean putting the clothes in the laundry and turning the washing machine on. See, then you have to take the clothes out of the washing machine and put them in the dryer. That's not done. Then you got to take them out of the dryer and fold them, and then you got to put them away. See, I stopped at every step and had to be educated. So The goal for women is to try and educate their partners. It's just because we're not dumb, but we can sleep through a baby crying with, pretending at least, because we don't want to get up in the middle of the night.
Right.
That's how we are, right? We just need to be educated.
Yeah, and guided. Yeah, it's funny you say that, because I'm like, my husband and my son, they're like, "What, Mom? We did the laundry." I'm like, "No, you put it from the washer to the dryer. You didn't start another load, and you left everything that needed to be folded, and some of it damp, on the table. Like, that's not doing the laundry. Any monkey can put laundry into a dryer and start a button, right?"
Yeah, I thought I was doing the laundry, but I wasn't.
I know that's what they think too. Well, we're working on that. So let's go to some questions here, because I know it's going to stir up some things that I know I want to ask you too. Okay, so what hormonal issues may be responsible, Kelly's asking, for hair loss that stops during ovulation and ramps up dramatically in the second half of the cycle?
Well, hair loss, is the hair loss, you said it's just during the front part of the cycle?
Yep, during ovulation. And then ramps up dramatically in the second half. So it sounds like she's got constant hair loss.
Well, what's happening is probably estrogen dominance, I would think, because what happens is progesterone actually decreases your conversion to dihydrotestosterone. So dihydrotestosterone is what contributes to hair loss. And estrogen, first of all, progesterone, if you think about it, when you were pregnant, that's usually when your hair is really great. And then after you deliver is when all your hair starts falling out again. Because when you're pregnant and your progesterone levels are super high, progesterone stops the hair growth in a phase called telogen phase, Telogen. And so the hair stops, the hair growth cycle, everything stops. So you don't lose hair. You're not really growing hair. Everything's perfect. And then what happens is your progesterone drops, it starts cycling again, and all your hair falls out. So if you don't have the progesterone phase to slow the hair falling out down in the second half, that's probably partly why that's happening.
Okay, so a Dutch test could show what's going on. And let's stop just for a second. I knew I was forgetting to ask you something. All right, so is it true that you should have your hormones tested if you're going to do it by blood, which I'm a Dutch fan. I mean, I have done it several times. But if you don't have a choice, right, and you don't have the money to do a Dutch, and your insurance covers conventional blood serum, is it true you should have it done on the 21st for women? Should they test their hormones on the 21st?
There's two ways to answer that. In a perfect world, yes, because that's going to give you your progesterone should be peaking around that time.
Okay.
The other way to look at it, because by the time I get patients that come see me, they've already seen 3 or 4 people and they're frustrated and they're pissed and they want to feel better now.
Yep.
So I'm not going to make them wait 3 weeks until they're on day 21.
Right.
I will do the blood testing right then and there. I'll have an answer in 2 days of where they are cycle day 5.
Okay.
Then what I'll do is when they come back in for their next round of testing, I'll try to get them on day 21. I just don't like them to have to wait. And you can usually make them feel better. But in a perfect world, yeah, day 21 would be great.
Okay. So, when it comes to doing the blood, what's the accuracy rate of blood? Because I have to say, I'd get my blood tests back and I'd be like, this doesn't go along with anything I feel. Like, this doesn't make sense to my symptoms at all. This is years and years ago. And I will say this, when I did, I had low libido and all of that. This is years, like probably 11 years ago. And then someone actually said, well, have you ever had your SHBG tested? Sex hormone binding globulin. I'm like, no. And she tested it and it was high. And she's like, well, it's probably binding up your testosterone. Like, those are pieces that no one ever told me, could be happening or going on. So can it be useful in those types of cases where someone is, dealing with particular symptoms, or is it just, how useful is blood serum? That's my question.
So I always tell patients, blood is extremely accurate because it's blood. The downside to blood is if you want to think of blood as a picture and the Dutch as a movie. Okay. So the like blood is extremely accurate, but it's only accurate for the second that needle's in your arm.
Yep.
So you might have felt okay when you had the blood drawn and, the next day it felt like crap. And that's the limitation with blood. So with blood, what you want to do is serial test. The more data points you get, that's why if I'm doing blood, I always tell patients, I'm like, look, I know you're frustrated. I know you're mad. I know you haven't been heard. But if you can stick with me for 3 to 6 months, I'll get this right. I promise. I just might need some more data points. So, but Dutch kind of speeds that up. So you don't need as many data points with the Dutch because you're getting more information.
Got it. So it's like a snapshot of what's happening in a moment in time. Okay. Exactly. Okay, perfect. All right. Chrissy says, I just want a period again, but I don't want to use anything from pharma. So, and I don't know Chrissy's story, but, I'm assuming that she's a cycling woman normally, and that something has stopped her cycle. Would that be something like low progesterone or?
Well, if she's not ovulating, then she's not making progesterone. So that could be polycystic ovarian syndrome. It could be stress. It could be something along the lines that maybe she's super thin and she's training for a marathon or something like that. It just really depends on where she's at in her, life.
Yeah.
But if it is something like PCOS, doing something like, trying to decrease weight would sometimes bring the period back, or using DIM diindolylmethane might help a little bit, but sometimes you got to add progesterone if you want to have the period. It just depends on the cause.
Yeah, there's a lot that could be going on there. I'm glad you mentioned that about the training and the marathon thing and all that. I actually have some close friends and people in the past that lost too much weight, lost their period because they weren't making hormones, obviously. But can you talk a little bit about what happens when someone gets too thin or they lose their body fat and the period goes away? Endurance athletes and things like that.
Well, the problem with endurance is that the basis, the structural basis for your hormones is cholesterol.
Mm-hmm.
So if you're training like that and you're burning away all your fat, and chances are you're probably eating a ton of calories, but maybe not a ton of good fats, that you don't have the reserves. And so here's what your body does. Your body needs to survive, right? So if you look at marathoners, and I mean no disrespect, but if you look at marathoners, a lot of them don't look healthy, right? They're super thin versus sprinters who are all muscular and everything.
Mm-hmm.
And it's just that in that endurance training, what it does is your body's going to say, okay, I cannot keep up this amount of caloric burning. I have to shut down some of my systems that aren't necessary for survival. And that's going to be your brain talking to your ovaries. You don't have to do it. It's not mandatory to live. It's got to run the gut. It's got to run the heart and the brain, but it doesn't have to necessarily make your hormones work as well. And so that's one of the systems that kind of shuts down.
Got it. Like the digestion and fertility, like those are not emergencies. When we're in the middle of a stressful situation, the last thing we want to do is have sex and digest our food, kind of like that.
Yeah, exactly.
Yeah. And I had this conversation with a girl at the gym the other day who's counting her macros and micros to look at her, to see her abs and get lean and all that. And she is alarmingly thin. Like she's lost all her breasts. Her bottom is flat. I mean, she is thin. And I said, I love you, but are you like having a period right now? And she goes, oh, I haven't had one in 7 years. Because she's been on a marina or something like that. And so I said, so basically you don't even have the intuition of your body saying your fats are too low, because you don't even have that natural, thing to tell you. So let's go there. What is harmful about being on birth control for an extended period of time and suppressing that natural part of our body? I mean, that to me, that's just, I didn't do that past age 19 was, suppress my period. How can that be damaging to us?
Well, there's a few women out there talking about that right now, like Nicole Hardham and Jolene Brighton and Elise Vitti, I think, are kind of talking about this post-contraceptive syndrome.
Yeah.
And I think there's something to it. I know Jolene Brighton's got a book that's coming out hopefully next year just on that topic alone. But it's one of those things where if you shut the ovaries off, the way that pills work is they turn the ovaries off because the ovaries don't need to make anything because you're getting exogenous hormones. So then the question is, when you stop them cold turkey, do the ovaries wake up? Do they not wake up? Do they go back to normal? And I think that's what we're seeing is that in a lot of women, it's suppressing testosterone, estrogen, progesterone long term. And so they're just not feeling well. Now, if you look at the IUD, like you talked about, the IUD is a little bit different. The Mirena does have a little bit of progesterone in it.
Okay.
The problem with that is that I bet in that case that you mentioned, she probably had the Mirena because she didn't want the inconvenience of a period if she was going to be racing, right? So I can see the functionality there. I have some female athletes, college athletes that use them because they don't want to be at a volleyball game and have their period start.
Yep.
So I can see that as well. But I would say, maybe after a few years, you should cycle for a few months. And then if you want to go back on, you can.
Okay. So they don't do as much damage as, like, say, oral birth control and things like that.
No, the IUDs are theoretically, especially the Mirena, the Skyla, they tend to be a little more localized to the uterine lining.
Okay.
The copper IUD obviously has no hormones in it at all. So.
Oh, let's talk about that, because that was the next thing I was going to ask you is how dangerous is copper toxicity a real thing with that particular IUD? I mean, because we're talking about a balance of, zinc and copper. I mean, we're trying to balance them right in our body. So if we're doing that.
Unless you have something like Wilson's disease where you can't process copper, probably not. But I'm sure somebody could argue that with me. But I rarely put them in anyways. People don't like them because they usually your periods are heavier when you have it.
Okay.
And most women don't want that.
Yeah, true. Okay. All right. Let me scroll through here and see what other questions are. Someone said the saboteur definitely resonates with her, Alexandra. Yeah, me too. Megan saying, I love that. Women don't have sex with jerks. True story. Jordan is saying, I had so much sex drive while I was pregnant and now it's non-existent. Is this normal? And that's a great question, because I was the same way when I was pregnant. I would have stayed pregnant for the rest of my life. I felt better than I've ever felt in my entire life when I was pregnant. Everything was like roses for me.
Usually it's because you're on a hormonal high. Now, some women obviously feel awful, but if you think about it, you're not cycling, right? You're kind of maintaining status quo. And so I think you feel better. And that's why I don't like pellets. That's why I don't like cycling. If I'm going to do hormone replacement, I try to get things to be kind of even. I think that just feels better than doing this,
Yeah.
And I think that's part of it. Plus, your testosterone levels, everything's kind of churning a little bit more because your FSH and LH are rocking. And so I think it's just an overall, for a lot of women, and there's I think more of a bonding process too with your partner, because you're pregnant, and it's just I think it's a different thing altogether sometimes.
Yeah. Okay. Yeah, and you just answered Vanessa's question. Why don't you believe in bioidentical pellets? And yeah,
I can tell you, I have a bunch of reasons if you want to hear them.
We want to hear them. Go for it.
Pellets are super expensive. Number one, they are a surgical procedure, so you have to use this trocar to dig a tunnel into somebody's butt cheek, and then you deposit the pellets in there. 3, you cannot achieve status quo. What happens is the first month or 2, your hormones go way up. I've tested so many women's hormones that are like higher than a man's testosterone with pellets. So you go super high, you feel great for maybe a month, and then it kind of crashes, and then you have to get them again. So every 3 to 6 months, you're getting a surgical procedure done, bruising, infection possible. And most of the people putting them in don't know how to put them in because they're not trained very well. The companies that do pellets like BioT, Sotapelli, things like that, they charge the doctor about $800 a month just to be a part of the program. So the doctors are more obligated to want to put the pellets in.
Right.
Whereas a prescriptive cream is $38, $40 a month. Pellets are probably $600. Wow. I just don't see the point personally.
Yeah, it makes me nervous to even think about. Someone told me I should do that at one time, and I'm like, I don't even want something permanent. I don't even know. Like, I don't even like contacts.
What do you do if you don't like them? If you don't like
that's it.
You're stuck.
Well, they'd have to take them out, wouldn't they?
No, you can't. You can't get them out.
What do you mean?
You can't take them out. They dissolve, but you couldn't get them out. They're so tiny, you'd never find them.
Oh my gosh. Oh, that just gives me the creeps. Like what you said about digging a what in someone's buttock and
you take a needle it's a trocar, and you have to kind of create a pocket so that when you deposit the pellets, they don't just come out.
Okay. That right there. You don't have to tell me anything else about pellets. Right there would have been enough to say never. I don't like needles. Okay. Oh my gosh. All right, Alexandra says, female, age 48, no period for over a year, all sex hormones lower below range and cortisol lower below range as well. Where do you even start? Do you treat the adrenals first? That's a good question, because a lot of people say that you have to start with adrenals or nothing else makes sense. Is that true?
I guess it depends. I was always on the boat for years. Gosh, the first 8 to 10 years that I was doing this, that I didn't really do much with the adrenals. The adrenal thing has kind of come to the forefront maybe in the last 5 to 7 years. Mm-hmm. And they're complicated. Although I would say a woman that has super high cortisol, she's going to be burning through things a lot faster. So if you can't get her cortisol down just because of who she is, type A, whatever, then yeah, you might need to try to bring the cortisol down, because you might need to use higher doses of hormones, or else she's just not going to get the bang for the buck. Not to mention the fact that the cortisol is just purely catabolic, and she's just, basically eating herself catabolically, muscle tissue and things like that. It's just obviously not a good place to be, blood pressure and sugar levels and all that stuff. Mm-hmm. So yeah, I would try to get those down. I think that's hard though. It's hard because it's lifestyle, right? Most of it, it's lifestyle. And It's a hard thing. It's hard to get a type A person to calm down.
Yeah, I 100% agree with that. I'm a triple A. I'm not even a type A. I'm a triple A personality. And the last 5 years of my life have been spent trying to figure out how to not be myself in certain areas of my life. So, I found that the Muse meditation headband really helps me to bring myself down. I've learned breathing techniques. I've really had to focus on that part that I'm not comfortable in. Type A's are not comfortable being people who stop moving and sit still. It's not our nature. But to me, that's a sign from the universe. Like, something you don't want to do is something you need more than anything. And so, like, even when you had mentioned to me, like, you were afraid I was going to burn out. Like, when I'm having more things happen in one area for stress of my life, I stop CrossFitting. If I'm have a lot of stress going on around the holiday, there's specific things I don't do. I might walk my dog slowly. I might do more of my quiet sitting. But that is definitely, you're right. It's hard to change that mindset and hard to do.
Well, interestingly enough, the archetype for the cortisol excess is, I call it the workaholic.
Yeah, 100%. Yeah, I believe that. And we're going to talk about your book in just a second, but let's answer the rest of the questions because we're getting close to the hour. Sure. Okay. Does birth control decrease libido?
Of course, we know that from studies now too, that because the birth control pill interrupts the communication between the brain and the ovaries technically shut down. Ovaries make about 50% of the body's testosterone. So that will cause a decrease in libido.
Okay, so the rest of the testosterone comes from where? The adrenal glands or?
Adrenals, yes.
Okay. So that goes back to another question for me. When people say, well, I've gone through menopause and I felt terrible for 2-3 years with hot flashes, but I feel better than I've ever felt. Now I want to have sex all the time, all of these things, but they obviously didn't restart their ovaries. So when the adrenals are they supplying all the hormones when someone feels that good and maybe they just reached a point of acceptance in their life and there's less stress? I mean, is that possible?
Yes, I think you hit the nail on the head with the second part. I bet if you tested those women, 95% of them would still be low in testosterone. But most of the sexual process for women is it's outside of their bodies. It's not like a guy. I always joke with patients, your husband can wake up with an erection and that's all he needs.
Oh, totally.
For women, it's not like you're all just walking around like with like dudes and you're ready at the drop of a hat. It's a process. And so if your kids are gone because you're 50s and they're going to college and you're getting to do the things that you want to do and you're sleeping better for Pete's sake, I think that's why sex drive goes up, to be honest.
Oh, I totally agree with that. And I'm telling anybody that's listening to you guys, if you're interested in that kind of thing too, the book Come As You Are for the ladies is really, really, really good. Like you're almost paralleling, like having a conversation with you today. It's almost like you and her wrote this book together. It's really
look her up. Yeah,
really good. Okay, so what do you like for bioidentical hormone replacement? If someone has to do that, creams, that kind of thing. Like, what do you suggest and what do you prefer? And you did mention capsules; they get kind of chewed up quite a bit by the liver and things like that. So, what's your preference?
Ideally, you want to use estrogens transdermally because they don't convert as much into the carcinogenic hydroxy formulation. Progesterones, if you're being a purist, actually are better orally. They work better orally. But because I'm really simplistic, I don't like to make, okay, you're going to take this pill at night, then you're going to use this cream in the morning. So if I'm giving a woman estrogen, progesterone, or progesterone, testosterone, more than one thing, I'll put it all into one cream just for simplicity's sake. If I'm getting kind of specific with a patient, like she's not sleeping good at all, then I might parcel out the progesterone and give it to her orally at night, just for the sleep aspect, and then put the estrogen, testosterone in a cream, for the morning. Okay. So it really just depends. But I would say 90% of what I do is a cream. There's also bioidenticals that are run by big pharmacy. Estrace is a bioidentical estrogen. The problem is it only comes in 2 doses, 1 milligram, 2 milligrams, and it's oral. So you're going to lose most of that. Prometrium is the bioidentical progesterone that's available. And again, it only comes in 100s and 200s. But the benefit to Prometrium, if I'm going to give oral, is that it's covered by insurance. So if I'm going to pull that out, I'll use it. And I do use DHEA a lot too. So that can go in the cream as well. So if some women don't like the creams, so I'll give them sublingual because it gets absorbed a little bit faster. Now you will swallow some of that.
Yeah.
But I used to do the sublinguals all the time. But what I was noticing is after about 2-3 months, your mouth gets really just kind of sensitive because these troches are in your mouth, and they take about 10 minutes to dissolve, and some people don't have the time for that.
Yeah, I remember when I first heard about troches about 8 or 9 years ago, someone said, "Oh, troches are the only way to do this, this, or this," and I'm like, "What in the world is that?" Isn't it like a for those people who don't know, isn't it like a gummy kind of a the texture of like a sort of like a gummy? Is that true? Yeah, and they dissolve under your tongue. Yeah, many people don't know like some of the language. Like transdermally is topically, you guys putting it on through your skin. Sublingual is under your tongue. Which is one of the fastest ways that you can absorb hormones. So tell me about what your thoughts are on mucosal, transdermal mucosal application. Do you agree with that in any way, or?
You mean like intravaginal?
Intravaginal, or even some people do it rectally, which I've heard of. I've never done that, but.
You're going to get great absorption that way. It's just messy. I mean, who wants to put things in their butt? I don't really see the point of that, but. I mean, seriously, I would be like, if I was going to take testosterone, he's like, oh, you got the one you can put on your skin, or you can put this thing in your butt. I'd be like, okay, is that a question?
Okay. All right. You got me tickled. That's hilarious. Okay.
But the vaginal suppositories, they're just messy because they break down and they melt and then it all comes out.
Yeah. Okay. So getting real. Perfect. Truth. I agree. Okay. So talk about, yeah, we got some laughter going on. Talk about tell us about your book. What's it going to be about? Why should we all read it? Which I mean, absolutely. Of course I'm going to read it. I need everything I can to put behind me learning how to not be a type AAA. When's it coming out? What's the title? Tell us about it.
Well, it's so early in the process. I'm actually going to New York in January to sell it. So, but in about 2 weeks, I'm going to have the quiz go live, and it's going to be whatsyourhormonetype.com.
Okay.
And it's going to be that 36 question quiz. It seems like a lot, but it really gives me a lot of information. And then you're going to get your hormonal archetype. You're going to get what your hormone type is. And then there's going to be options, as we see in most cases, where you can learn more about it if you want and get some quick fixes. Like I'm going to have a deal where everybody that takes the quiz is going to get a free 2-month supply of Feminescence maca product to help balance their hormones immediately. I'll also give some tips. So that's going to be whatsyourhormonetype.com. And then the book is going to come out towards the end of that, so that like the thing about this that's really cool too, I think, is that you might be the queen now, but 3 years later you might be the underdog or something like that. So you're going to go in and out of these, but you don't necessarily have to read the whole book. It's going to be color coded for each archetype, and you can take the quiz multiple times and learn about those as you want. So then for you all, this is going to be for patients and you, obviously. But then once I get that going, I'm really, really, really wanting to have coaches that know this stuff. And so I want to train coaches that are familiar with the system that I'm doing on spiritual practice, hormones, infoceuticals, nutrition, exercise, and supplementation to fix all these. So I'm going to have a website then where the patients can find the coaches in their areas that want to work with them.
Awesome. And of course, anyone in the Institute, of course, you guys, this is something you need to think about. It's part of, part of the 7 essentials when we're talking about stress and all of those things. Yeah, people are like, count me in. Absolutely. So you and I will have to collaborate because when the book comes out, I would love to bring you back and just, have a way for everyone to connect with you. I know we talked about you providing training for the Institute as well. And anyone, and it'll be open to, and just FYI, you guys, the training of the experts that's out there right now, anyone, even if you're not a student, you can buy the training. So that's what we're going to be offering through Shawn as well. So this has been really interesting. Just having, a different perspective, and, I respect your work. I'm lucky enough to be able to get to see you for 2 seconds in the hallway at Mindshare. But still, and have watched you grow a little bit in the last year, actually, from meeting you the first time and seeing what you're doing. And you're really doing something different. And
Actually, I've shrunk. I've lost like 30 pounds. So
you know what I mean. But you're doing something different than I'm seeing, and it's refreshing. And just want you to know. And I think your wife has done a really good job with educating you for us women.
yes, she has. And actually, but the thing is I'm teachable. See,
Yes,
that's the key piece. Got to be teachable.
Oh my gosh. We should have a completely different webinar on how to be teachable and have our husbands on with us and our spouses and our partners, because that's not easy, right? It's not easy to find a man that is coachable or teachable to learn about what women need and what, what we are and why we are the way we are.
No, but my wife is an alpha and I'm not. So that's how it works.
Perfect. At least you recognize that, right?
Totally.
If I keep trying to tell my husband, if he just, go along with me, everything would be great, but it doesn't seem to be working. So
like from here, I'm going to go do the laundry and I'm going to dry it, fold it, and put it away. See?
I don't believe it. I want pictures of that. Okay. Yeah. Next, I see a book in your future, How to Be Coachable or Teachable for Husbands.
Oh, nice. Would anybody read it?
Heck yeah. It'd be the best Christmas gift ever. And Father's Day.
All the women would read it.
That's right. That's right. That's true. All right. I will talk to you outside of this, and we'll, keep in touch when your training's going to be ready. Thank you so much. We need to clone Dr. Tassone. That's funny.
Don't tell my wife that. Oh my gosh.
Oh my gosh. Yeah. But we just appreciate you and your time, and hope you have a great Thanksgiving, and you and I will communicate soon. I'll talk to you soon. Thank you.
Bye.
Bye.